Hello everyone and welcome to our Step 1 video on inflammation. Now before we get started, I have someone here that I need you to meet. I would be nothing if I didn't have my trusty sidekick and cameraman Travis. Say hi, Travis.
Hello.
Travis is the best of the best. His skills behind the camera are a critical part of the creation of these videos. Isn't that right, Travis?
I guess. Can we just shoot this?
Right you are, Travis. So, how do I look?
Let's see, a little bit to your right.
Okay.
A little bit more. Right there.
Really? I seem to be, I don't know, a little bit not in frame.
I don't know, man. This is looking pretty good from here.
I hear what you're saying, I don't disagree, but maybe, I don't know, here.
Whatever, it's all the same to me.
All right, on to inflammation. Now, sometimes injured tissues undergo necrosis, which you covered in the previous video, but sometimes the body initiates an inflammatory response to try to repair the damage. So we're going to talk about some inflammation. So inflammation, again, characterized by redness, swelling, warmth or heat, pain, and some loss of function. Now, there are two big categories of inflammation: acute inflammation and chronic inflammation. So let's start with acute inflammation first. Now, acute inflammation goes through several different stages. First, you have some type of injury or insult, and that leads to the release of specific cytokines and inflammatory mediators. Now, the inflammatory response is associated with acute phase cytokines. And what are those? IL-1, IL-6, and TNF-alpha. Now, make sure you know those. Associated those in your mind with inflammation: interleukin-1, interleukin-6, and TNF-alpha. Now, these cytokines do a lot of things, like cause vasodilation, and they increase vascular permeability. So that plasma starts to exude into the interstitium, and that causes swelling and redness and so on. Now, exudation of those inflammatory fluid is going to be measured or mediated by three specific chemicals. I want you to remember histamine, serotonin, and bradykinin. So make sure you know those also: histamine, serotonin, and bradykinin. Then eventually you're going to develop fibrosis, where fibroblasts get into the tissue and start laying down extracellular material, specifically collagen. And we'll go over collagen in detail in a later video. But for now, I want you to know that vitamin C is important in this process of fibrosis and making collagen. Then over time, that extracellular matrix needs to be degraded and remodeled into something more organized. Now, the enzymes that do this are the metalloproteinases. They're called metalloproteinases because they require a metal in the enzyme, specifically zinc. So that's another substance that's vital in the healing process, zinc. So you need vitamin C and you need zinc. Now, there are different outcomes of the acute inflammatory processes. Ideally, the normal structure and function are restored, and it's like the injury never happened, and that's called resolution. Now, conversely, you can develop scarring. What's that? Well, scarring occurs when, instead of healing normally, you lay down all this collagen that contracts and forms that scar, and that's going to leave some residual abnormal function. So, for example, if you have an MI, there's a scar that forms in the myocardium, and that scar can't contract normally or relax normally or conduct the electrical impulses normally. So scarring of the heart can lead to a variety of different types of tissue dysfunction and organ dysfunction. Now, sometimes you'll get organization, where you get an organized fibrotic shell that kind of walls off inflammation from the rest of the body. And if that maybe fills up with pus, we call that an abscess. So your body actually considers an abscess a success because you've segregated that infection so that the pus pocket can't cause problems for the rest of the body. And then finally, sometimes with acute inflammation, and maybe you can't get rid of whatever's causing it, then you have that progression to chronic inflammation. So let's switch gears and talk about chronic inflammation. So chronic inflammation causes cycles of tissue destruction and repair, and more destruction and then more repair. Acute inflammation and chronic inflammation are really mediated by different cell types. Now, acute inflammation is mediated primarily by neutrophils, and then chronic inflammation is mediated more by mononuclear cells like macrophages and lymphocytes. And those macrophages are the reason why with chronic inflammation you can have formation of granulomas. Now, granulomas are clusters of macrophages that are found in chronically inflamed tissue. So you can see this kind of central area of macrophages, and then surrounding these macrophages are inflammatory cells like lymphocytes and fibroblasts. Now, sometimes some of the macrophages will fuse their plasma membranes and cytoplasm, and then you get the multinucleate giant cells. So with granulomas, you can see these multinucleate giant cells. Sometimes they're just called giant cells. Now, macrophages start out as monocytes in the blood, but when they leave the blood vessel and migrate into the inflamed tissue, we call them macrophages. And macrophages surround and consume and destroy invading microbes, and they also clean up the cellular debris from all those tissue injuries and inflammation. But when the macrophages don't get shut down appropriately, they keep eating away at healthy tissue, so now they are causing local destruction, and the body has to respond to the damage that the macrophages are causing. So with chronic inflammation, you see this ongoing cycle of tissue damage and then repair. So now let's move on to neutrophil extravasation. What a nice word. So how do these different types of white blood cells get out of the bloodstream and then into the tissue? So we call this leukocyte extravasation. Now this could be neutrophils, also called the polymorphonuclear cells, or the PMNs, or other granulocytes, or it could be monocytes, or it could even be certain types of T cells. They all use the same basic mechanism. So there are 4 steps that we need to go through. So the first step is that the neutrophil gets sort of sticky and it starts to roll along the vascular endothelium, the inner surface of the blood vessel. Now imagine that you're jumping out of a train at high speed and you sort of kind of bounce and roll along the ground as you come to a stop. And actually, this rolling process allows the endothelium to select for certain types of neutrophils that are going to pass through the endothelium. So this is the selection process, and it's called, funny enough, rolling. Now, on the surface of the endothelium, there are proteins called selectins that are involved here. So there's E-selectin, and E is for endothelial cells, and there's P-selectin, and the P is for platelets. And there's also L-selectin, which is found on leukocytes. So think about this. You can't have these selectins expressed on the surface of the endothelial cells all of the time, or else you would be constantly extravasating neutrophils all the time. Now, you want to have some control over this process. Well, the signal that tells the endothelium to start throwing up all these selectins to flag down some of these leukocytes are those acute phase cytokines that we talked about before, IL-1, IL-6, and TNF-alpha. So these are going to make the endothelial cells, quote unquote, kind of stickier in that area. So they are selecting more neutrophils. Now, the next step is tight binding, which involves surface receptors called ICAM1 on the endothelial cells, and then the LFA1 on the leukocyte. Now, the LFA1 is part of a family of cell surface receptors called integrins, which helps the cell to attach to external things, like other cells or extracellular matrix. And you can remember that integrin helps the leukocytes integrate. Step 3 is diapedesis. So this is where the leukocyte works its way between endothelial cells and escapes the blood vessel. Now, PCAM1 is the molecule involved here. PCAM1 is found on the intercellular junctions between endothelial cells and also on the neutrophils and monocytes and even platelets. And then step 4 is migration, where the leukocyte travels through the interstitium to kind of wherever it needs to go, so the site of injury or inflammation. And we need to remember that these are just cells, right? They don't have a consciousness or complicated mental capacity. They don't know where to go. They're just sensing all these chemical signals that guide them to where they need to go. So these signals are called chemotactic signals, and they can be like things like bacterial products. So a bacteria will produce substances that have the beneficial effect of attracting neutrophils, but really just beneficial to us, not really so much for the bacteria because we're going to kill it. Now, there are also signals that our bodies make called neutrophil chemotactic factors, which we'll see again in immunology. So there's C5a, which is a component of the complement system. There's IL-8, there's LTB4, and there's also one called kallikrein. Now, you should make a note of a couple of other points here. The process of binding, diapedesis, and migration is enhanced by platelet activating factor. And it might seem a little weird that platelet activating factor would enhance leukocyte extravasation, but it also makes some sense as well. So if you have a vascular injury, an endothelial injury, you're going to want to activate platelets to stop any bleeding, but then you also need to recruit those leukocytes to help get that little inflammation going and patch up the injury, right? Because again, that's the point of inflammation, to heal an injury or an insult. Now, the last point I'm going to throw in here is that there's an immunodeficiency disorder called leukocyte adhesion deficiency. Now, from the name, you can probably tell that this is a problem relating to leukocyte adhesion. Now, specifically, you have abnormal LFA1, so that integrin molecule, and this affects the tight binding step. Now, we'll cover this again in immunology, but the classic presentation of leukocyte adhesion deficiency is delayed separation of the umbilicus in newborns, and then again later, you get recurrent bacterial infections. And that's because without normal integrins, you can't get leukocytes and macrophages out of the blood vessels and into the tissues to fight infections. Now, there are dozens of chemical mediators that influence inflammation, things like prostaglandins, leukotrienes, nitric oxide, thrombin, and so on. The point is that this is a really complex, tightly regulated process. Now, we're painting an extremely simplified picture of it all. We're just focusing on what you're most likely going to see on your test. Let's move on to transudate versus exudate. So in inflammation, it's going to make the blood vessels dilated and very leaky. And besides leukocytes leaving the circulation and getting out into the interstitium, you're also going to have fluid that does the same thing. Extravascular fluid can be categorized as either a transudate or an exudate, and it's really just based on its composition. Now, transudate is going to be a very watery fluid, and exudate is going to be thick and kind of full of stuff. So think about transudate as being mostly water. It doesn't have a lot of cells in it. It doesn't have a lot of protein in it, and has a low specific gravity. And because it doesn't have a lot of stuff in it, think of it as being maybe transparent. You can see through it because there's not a lot in the way. Now, transudates can form because of high hydrostatic pressure. So pressure is basically pushing serum out of the vessel and into the tissue. Or it can also be due to decreased oncotic pressure. Now, proteins in the serum exert an osmotic pressure that tends to draw fluid in. But if your serum is really low in proteins, then you lose that effect and fluid will leak out of the vessel. So if transudate is watery and doesn't have much stuff in it, then exudate is the opposite. Exudate has a lot of stuff in it, so it's rich in proteins, it's rich in cells, specifically inflammatory cells. Now, one student sent in a mnemonic that the EX in exudate can remind you that exudate has extra stuff in it. So maybe that can help you remember it. Now, exudate can form due to lymphatic obstruction, also inflammation that we talked about so far. And we'll talk about transudates and exudates again when we get to ascites and cirrhosis in the GI section. All right, so now let's move on to granulomatous diseases. So that's enough for acute inflammation again. Now let's back to chronic inflammation. Remember we said that chronic inflammation usually involves macrophages, and that chronic inflammation is characterized by those ongoing cycles of tissue damage and repair. Now, there is a specific pattern of chronic inflammation that I want to highlight again called granulomatous inflammation. And this is where you have the formation of granulomas. So what is a granuloma? So remember we said that it's a little collection of macrophages, and these macrophages make a TNF-alpha, which perpetuates that inflammatory process and maintains the granuloma. Now, some of the drugs that we use to treat chronic inflammatory diseases like rheumatoid arthritis, Crohn's disease, some of those drugs, for example, like infliximab, block TNF-alpha, and that's going to cause the granulomas to break down. So let's talk about a scenario. If you have latent tuberculosis, where your body sequesters the TB mycobacteria into the granuloma in the lung, then you give that patient, say, infliximab. You tear down the granuloma. What's going to happen? Well, that TB mycobacteria are no longer in lockdown, and now they're reactivated into active TB. So before you start an anti-TNF-alpha drug, you always do a TB test to make sure that the patient doesn't have latent tuberculosis. Now let's go through some of the diseases that cause granulomas. Make sure that you know this list, because you might see a question where they describe granulomas on a biopsy, or they might show you a picture of a granuloma, and then you'll need to mentally run through the list to see which is most likely given the clinical scenario. So you might want to write some of this stuff down. Now, we mentioned that tuberculosis causes granulomas, and frequently with TB, these granulomas are what we call caseating, or caseous is going to mean cheese-like, and that's referring to the kind of gross appearance. You see this kind of yellow white stuff that looks like cheese. It's pretty gross. And then microscopically, in the middle of these granulomas, there's caseous necrosis. So you see this central area of pink amorphous material. Now, it's not completely specific, but if you see caseating granulomas, then you should probably think about TB. Now, there are other pulmonary diseases associated with granulomas as well. For example, fungal infections like blastomycosis and histoplasmosis. Sarcoidosis causes granulomas, and we're going to cover that in our pulmonary section. Granulomatosis with polyangiitis, that's what we used to call Wegener granulomatosis. So this is, again, covered in another section, our cardiovascular section. It's the form of vasculitis that's going to cause granulomatosis inflammation in the lung and the kidney. Berylliosis causes granulomas. Who gets berylliosis? People who work in beryllium mines. Churg-Strauss syndrome, that's also referred to as eosinophilic granulomatosis with polyangiitis. That's another autoimmune disease that can result in granulomas. And then moving away from pulmonary diseases, cat scratch disease can cause granulomas, and this is caused by Bartonella hynsula. There's listeria. Leprosy can cause granulomas, and also syphilis. And then Crohn's disease, another form of an inflammatory bowel disease where you're going to get granulomas in the GI tract. So here's a section of colon in a patient with Crohn's disease, and you can see the intestinal glands or the crypts here. But what you really need to notice is this granuloma right here. This is a non-caseating granuloma, so you don't have that amorphous pink center. You do have this collection of macrophages surrounded by inflammatory cells, and then even some multinucleate giant cells. So again, if they show you an image of a granuloma and they tell you that's in the GI tract, then they might be trying to get you to make the diagnosis of Crohn's disease. But if they tell you that the granulomas are in the kidney and the lungs, maybe they're steering you towards Wegener. Or if they tell you that it's in the lung, it could be a bunch of stuff, but maybe they tell you the patient's a migrant worker who's been coughing up blood. That's certainly going to suggest TB to you. So they'll have to give you some clues. Now, there's also an immunodeficiency disorder called chronic granulomatous disease, which of course causes granulomas, and we'll talk about that in our immunology section. And finally, you can see granulomas associated with foreign bodies. So one of the ways our bodies deals with a foreign body is to kind of surround it, engulf it, wall it off with a giant granuloma. So foreign bodies can cause granulomas as well. Next, I want to talk about two important markers of inflammation, the ESR and the CRP. So ESR is the erythrocyte sedimentation rate. Sometimes you'll hear it referred to as the SED rate. So this is a test that measures how fast erythrocytes are going to sediment, so how fast the red blood cells settle down to the bottom of a test tube or a pipette tube. So when you put blood in a pipette tube, inflammatory debris like fibrinogen will coat the red blood cells so that they kind of clump together more quickly. And this will cause them to sediment faster. So in inflammatory states, there's more fibrinogen around. The red blood cells are going to settle faster, and that SED rate is going to be said to be higher. But it's important for you to know that the SED rate is extremely nonspecific. An elevated ESR can mean almost anything. Specific diseases where you almost always see an elevated SED rate would include things like inflammatory joint or muscle diseases like polymyalgia rheumatica, rheumatoid arthritis, SLE, vasculitis diseases, things like temporal arteritis. Infection of almost any kind will increase the SED rate, as well as malignancy and even pregnancy. Now, another nonspecific lab test that we use to detect inflammation is the C-reactive protein, or CRP. So this is another acute phase reactant like fibrinogen, and like the ESR, this is also elevated whenever there's acute inflammation. Now, CRP is made in the liver by hepatocytes, and we think that it's probably going to function to help clear bacteria by binding to microbial surfaces and then acting as an opsonin. So whenever there's active inflammation, you might see an elevated SED rate, you might see an elevated CRP, or there could be other systemic manifestations of inflammation, such as fever, leukocytosis, an elevated heart rate, blood pressure, all sorts of things that might mean mediated by cytokines. Now, all right, so that's going to be it for the lecture part. Now it's time for that end of session quiz. Try to answer all those questions on your own, and then we'll go over the answers together. First question, describe the process of leukocyte extravasation. So there are four big steps, remember. First there was rolling, which is mediated by selectin, so they select the leukocytes. And then there's tight binding, and that's mediated by what? The integrins, they help to integrate. There's diapedesis, which is mediated by PCAM1. And then there's migration, which is mediated by the chemotactic factors, things like IL-8, LTB4, C5a, and kallikrein. Next, what cytokine is particularly important in the formation of granulomas? So remember, it's going to be TNF-alpha. Next, what cell type plays a role in inflammation by generating fibrinogen and C-reactive protein? Remember, that's going to be hepatocytes. And the last question here, what cell is most responsible for the acute phase of inflammation? So remember, it's going to be that good old-fashioned neutrophil. So remember, acute inflammation mediated mainly by the neutrophils. Chronic inflammation is going to be mediated by monocytes and macrophages. All right, guys, that's it for the video. I hope you learned something. I'll see you next time.